Welcome to this presentation on the inclusion of health in the minimum expenditure basket. In this PowerPoint, we're going to be looking at what some of the best practices to including health in the minimum expenditure basket and different responses to address health needs reflected in the MEB. I want to begin by first introducing the analytical framework we will use to analyze barriers to health. You will see this diagram a lot in this web series. This diagram shows the different barriers to health coverage using the Ta-Nehisi model that both health actors use and CVA actors can use as an entry point. Understanding these different barriers to health is a critical step in analyzing how best to respond to health needs. From the cash actor point of view, it is precisely where the barriers are financial that there are entry points for cash and voucher programming to support health outcomes. You will notice at the bottom of the diagram, the long bar in red represents the people of concern who are seeking health care, while the long bar at the bottom of equal length represents the goal, which is ensuring the right to health for all. The next bar up from the bottom is availability of coverage. This is the first question health actors ask, particularly in an emergency context where health facilities may be damaged or destroyed. Are there any hospitals? Are they well equipped? Are there health workers? Are medical supplies available and of good quality? The second is accessibility coverage, which is, do people have access to these health services? How far away are they? How far do they have to travel to access these health services? And is there a key financial barrier to be found in accessing these services? Acceptability coverage comes next. Do people feel well respected and well treated? Are they willing to use this service? Are there any language barriers? The next barrier is contact coverage. Who actually comes into contact with the health service? And finally, the last barrier is effective coverage. Of those who do come in contact with the health service, do they receive quality services or proper treatment? Each of these elements, each of these barriers can be addressed by different types of programming. It helps to think about whether programming should be on the supply or the demand side, or maybe a hybrid of the two. So why is CVA in health important? Addressing health needs is quite different from other sectors. This is because illnesses and health needs are unpredictable and not equally distributed across families as you would see with other needs such as food or wash. The cost of services are also not always averaged, as there is not necessarily a market price for health services, meaning there is no consistency with the cost of accessing health services, whether it be private or public. Also, where there are out-of-pocket expenses, households often delay seeking care, and patients often have worse outcomes. Delay can come from trying to find ways to cover these health costs. But health expenditures cannot be ignored. Household expenditure surveys and PDMs consistently reflect that household expenditures for health are in many cases one of the top 3 expenditures, and lack of funds is frequently also mentioned as a barrier for accessing essential health services. Finally, even when there are policies in place for health services to be provided for free, households still report direct and indirect expenditures relating to health, whether it be to see a doctor or to pay for medicine or pay for transportation to go see that doctor. What do we know so far? We know that CVA can have an impact on both direct and indirect costs to accessing health services. We also know that CVA can and has the potential to improve access to health services by removing some of the financial barriers to accessing and receiving those services. Such examples include, for instance, vouchers to reimburse prioritized health service or cash for medicine or transportation. CVA for Health can also directly address barriers related to financial accessibility and utilization. CVA can improve and contribute to people accessing health services and actually using them when in some cases they may not be able to afford them. Indirectly, CVA has demonstrated to have effects on availability, social-cultural barriers, and quality of care for effective coverage. Finally, CVA can also incentivize or encourage households to use a specific service which they may not have otherwise used. In using CVA for health, there is a continuum in programming. As we move from right to left, there is greater complexity, but also bigger impact beyond the patient to the healthcare system. On the left-hand side are simple cash transfers, best used with a case management approach. The further to the right we go, the more sophisticated interventions and also programming that may well improve the quality of the healthcare provided. But with greater complexity in design on the right-hand side, these programmings take more time. Programming on the right is more likely to be possible in long-term humanitarian contexts rather than rapid responses. When assessing whether CVA for health outcomes can be effective, it is important to understand what the health-related expenditures are, and if these expenditures pose barriers to accessing health services. For instance, we need to understand if people are paying for services from private providers rather than seeking services from public providers, and if so, why is that? Equally as important is to understand whether or not the service or medicine being paid for are of adequate quality, to make sure that using CVA does not encourage patients to seek services or buy medicine from unqualified doctors, increasing the risk of receiving poor quality care. Even when health services are provided free at the point of delivery, household surveys indicate that people always have health-related expenditures. In many cases, these expenditures are catastrophic to the household, pushing them into extreme poverty and negative coping mechanisms. Finally, we will have to understand if these expenditures are related to accessing health services directly or indirectly. Direct costs are those that are linked to accessing health services, such as paying for primary or tertiary care, paying to see a doctor or a specialist, or paying for medicine, whereas indirect costs are more related to costs incurred for attempting to see a provider, such as lost wages, transportations, and accessing the medical facilities. According to how a minimum expenditure basket is assessed, if households report health-related expenditures, these expenditures should be reflected in the MEB as they are with food and shelter. However, some health actors argue that because the best system is healthcare being provided free of charge to all those who need it, health expenditures should not be reflected in the MEB, but rather taken care of through other forms of health programming. In most humanitarian contexts, systems are not providing free health care, and it will take time and significant investments before they might be able to do so. So what do we do in the meantime, particularly as households continue to report significant health-related expenditures, whether it's accessing health directly or indirectly? But it is important to note that including health needs in the MEB does not necessarily mean that multi-purpose cash can address this in a comprehensive fashion. Multi-purpose cash could address the indirect costs, but the direct costs should be dealt with through a health systems approach. It is therefore important to understand why these healthcare costs exist and how best to address them. So knowing this, and knowing that there are health-related expenditures, how then do we determine the health portion of the MEB? There are three recommended technical approaches. The first approach is based on the costing of a high-priority package. The second approach is based on the household expenditure surveys. And in the absence of either of these two approaches, the third approach is using the health expenditure as an optimal portion of the MEB. I will go into more detail on each approach. The first approach is equivalent of the market approach and is informed by health system assessments, which should then lead to the definition of the essential services that a household needs, and then the cost of accessing or receiving those services. Such package could then be costed and thus translated in an average cost per person per year. This would give a reference for the total cost to deliver these packages for a humanitarian target population. Deducting the contribution from other actors, such as the government or humanitarian actors, leaves an amount that could then be included in the MEB, because it is assumed that this is the cost that households will incur if they are not covered by donors or humanitarian actors. This package, however, may not include indirect costs, such as transportation or accommodation for a caretaker. It would also not account for the fact that people may need services not covered in the package, such as medicines or accessing a traditional healer. For this reason, more detailed household health expenditure surveys are needed to better understand health expenditure patterns, including direct and indirect costs. The second approach is related to household expenditure surveys. These surveys reflect the real expenditures that households have related to health. However, health expenditure surveys do not necessarily reflect the real need for utilization of health services, as often households spend less than what is needed for their health because they cannot afford to take care of all their health needs. The amount for the health expenditures reflected is thus often an underestimate of the real health needs. Therefore, the amount for health expenditures estimated through household expenditure surveys provide a practical reference to include health in the MEB. However, it is important to note that the amount in the MEB needs to be adjusted when new interventions are introduced, such as supply-side interventions. And finally, if neither of the first two approaches are possible, then we can use a third approach. However, this is the least preferred option. Within a health system financing strategy, the aim is to keep households' out-of-pocket expenditures for health as low as possible. When households spend more than 10% of their total household expenditures on health, these become catastrophic, leading to negative coping mechanisms. From a program design perspective, this would mean that the proportion of the MEB for health should be less than 10% of the total MEB. Despite not having health-related expenditure data, the reason to still keep a portion of the MEB for health is to acknowledge that households still have health-related expenditures, and therefore we have to acknowledge this. Once more health-related data is collected, the MEB can then be adjusted accordingly. So how do we move from MEB to response options? The best response option for reducing direct health costs is first to explore mechanisms to reduce the user fees, such as supply-side financing. These approaches should and would significantly reduce the need for households to pay for a health service from their monthly income. This would lower the proportion of unmet need that remain, such as the cost for transportation or medicines. As previously noted, MPC can be effective in addressing indirect health costs. Otherwise, if we don't look for ways to reduce the user fees, the multi-purpose cash would unintentionally contribute to a culture where people are paying for health services, which would undermine the goal of financial protection for health and progress towards universal health coverage. They would also be likely to pay too much for the wrong service and be looking for essential health care far too late. This concludes our presentation. You can find out more on CALP's website as well as the website for WHO's Health Cluster Cash Task Team. Thank you very much for listening.